The following episode is brought to you by the American Urological Association. This special episode comes to you from the AUA Update Series. The AUA Update Series is renowned for delivering high-quality lessons to practicing urologists, fellows, and residents. All content is developed by internationally recognized experts in urology, making the AUA Update Series the most professional and sought-after self-study program available. The AUA Update Series is comprised of 40 lessons delivered to you in 5 lessons a month for 8 months. We hope you enjoy this episode, and if you are interested in learning more about the AUA Update Series, please visit the AUA University at auanet.org/university.
AUA Update Series, Volume 43, Lesson 39, Penile Duplex Doppler Ultrasound in the Evaluation of Sexual Dysfunction. Authors Melissa Egert, MD, Thero Pereira, MD, and Helen L. Burney, DO, MPH. History of Penile Duplex Doppler Ultrasound. The use of a penile duplex Doppler ultrasound to assess blood flow during a pharmacologically induced erection was first described in 1985. Since then, it has emerged as a reliable and non-invasive means of screening for vascular and anatomical abnormalities in the penis. A penile duplex Doppler ultrasound uses a small ultrasound probe and high-frequency sound waves to evaluate structures within the penis, including the corporal bodies, blood vessels, and blood flow. Clinicians can use this technology to screen for vascular abnormalities affecting erectile function, as well as detecting curvatures or plaques in patients with Peyronie's disease. In fact, penile duplex Doppler ultrasound is the most reliable and least invasive way to screen for vascular abnormalities. It is cost-effective and can be easily utilized in the office with minimal risks. When deciding how this technology would be useful in your practice, you should consider what equipment you will need, which patients would benefit from this diagnostic evaluation, how best to perform the ultrasound study, and how to interpret the results and make clinical decisions using this information. Equipment considerations. Penile duplex Doppler ultrasound is best performed using an ultrasound machine capable of color Doppler waveform analysis and a high-frequency 10 to 15 MHz probe capable of evaluating the structure of the erectile tissue and the tunica albuginea, as well as delineating cavernosal arteries and recording the erectile hemodynamics. A device to store the images as well as a printer are useful. Erectile hardness of the patient, medication and dosing used, and time intervals along with reported hemodynamic measurements as well as curvature and/or deformity measurements should be documented in the patient's chart. Other than equipment necessary to perform the test, there are also considerations on items to have in the office to help make the patient more comfortable and to obtain a more accurate examination. The goal is to try and recreate the bedroom erection in the office. The clinician may even want to give patients a survey asking what makes them most relaxed while in an artificial setting. Factors that may be important and play a role in a patient's comfort level during the penile duplex Doppler ultrasound examination include presence of bright lights, hallway sounds, room temperature, and the presence of staff within the room. These factors may negatively affect their erection. Some considerations to help make the environment more inviting include briefing the patients beforehand on what to expect, using a spacious, clean room, dimming the room lights, use of a sound machine or gentle background music, warming the gel lubricant before starting the ultrasound, conducting the ultrasound in a quiet room without much traffic, such as a room toward the back of the office, minimize talking during the examination, and educating the patient on when and how to call staff back into the room once they achieve a rigid erection. The use of visual aids to assist the patient in obtaining an erection may minimize the amount of medication needed to achieve an erection for the study. Candidates for penile duplex Doppler ultrasound. Penile duplex Doppler ultrasound is a useful tool in the evaluation of patients with sexual dysfunctions. Specifically, it can be used in a diagnostic and therapeutic setting for individuals being evaluated for erectile dysfunction, as well as a diagnostic and surgical planning tool for patients with Peyronie's disease. In addition, penile duplex Doppler ultrasound has implications in penile trauma or fracture, penile pain, priapism, and evaluating for a penile foreign body, such as a retained bullet, retained needle, or other foreign body that may be leading to sexual dysfunction or penile pain. Penile duplex Doppler ultrasound can be used to evaluate penile fracture or trauma. Although MRI may show more detail to diagnose the location of penile fracture, ultrasound may be more readily available in certain institutions, especially on nights or weekends, and is less expensive. Penile Duplex Doppler ultrasound can help establish the origin of a patient's erectile dysfunction by assessing blood flow within the penis. It can not only determine if a patient has a vascular component to their erectile dysfunction, but also if it is caused by corporal veno-occlusive dysfunction versus arterial insufficiency. It also allows the clinician to evaluate the penis for anatomical abnormalities within the penis. In terms of being a therapeutic agent, penile duplex Doppler ultrasound can be used in patients with primarily psychogenic or adrenaline-mediated erectile dysfunction, and patients can see the evidence that they have normal blood flow and are able to get an erection with intracorporal vasoactive agents. In addition, men who no longer respond to PDE5Is can see in real time how intracorporal injection therapy works, as well as have an idea of the dosing required to obtain an erection sufficient for penetration. If a patient is not able to get a rigid erection after intracorporal injections therapy, this may indicate that the patient is no longer responsive to oral medications or intracorporal injections, and that the next step in treatment could be a penile implant. Additionally, if a patient is able to achieve a rigid erection with normal hemodynamic values, erectile dysfunction resulting from macrovascular disease or atherosclerosis of large vessels, such as the coronary arteries, aorta, or large arteries in the brain and limbs, can be excluded. Penile duplex Doppler ultrasound can be utilized to assess blood flow in a patient with Peyronie's disease while simultaneously allowing the clinician to assess curvature or deformity and plaque by physical examination during a rigid medically induced erection. The AUA guidelines state clinicians should perform in-office intracorporal injections with or without penile duplex Doppler ultrasound before invasive intervention for Peyronie's disease. Penile duplex Doppler ultrasound can identify plaques that are not easily palpated, detect calcifications, and measure erectile hemodynamics in men with erectile dysfunction before surgical correction for Peyronie's disease. In addition, it is a reliable means for detecting plaque calcifications with reportedly 100% sensitivity. This may be important to identify before choosing a treatment because calcified plaques respond poorly to medical therapy, may be challenging for a needle to penetrate in intracavernosal injection therapy, and are unlikely to resolve spontaneously. Further, plaque excision for Peyronie's disease may result in worsening erectile function in a man with already compromised erectile hemodynamics on penile duplex Doppler ultrasound. Therefore, ultrasound is a reliable means for determining the best treatment options in men with Peyronie's disease and erectile dysfunction. In settings of penile trauma or fracture, penile pain, priapism, or evaluating for a penile foreign body, such as a retained bullet, retained needle, or other foreign body, a penile duplex Doppler ultrasound may be useful. Penile duplex Doppler ultrasound can be used to evaluate the structural architecture of the corpora when evaluating penile fracture or trauma. Although MRI may show more detail to diagnose the location of penile fracture, it is expensive, may take longer to be performed, or may be unable to be performed based on the timing of patient presentation and radiology availability. Here, ultrasound can be used. Ultrasound may be more readily available in certain institutions, especially on nights or weekends, and is less expensive. For priapism, in cases when the diagnosis of acute ischemic versus non-ischemic priapism is indeterminate, penile duplex Doppler ultrasound is an excellent tool for differentiating the diagnosis, and for cases of high flow or non-ischemic priapism, it is useful for assessment of fistula location and size. There is no indication for the use of penile duplex Doppler ultrasound in the evaluation of other disorders of sexual dysfunction, including anorgasmia, low libido, or premature ejaculation. Technical considerations. There is currently no standardized protocol for performing a penile duplex Doppler ultrasound, which results in high results to interpretation variability. A survey given to providers in the International Society for Sexual Medicine showed almost 90% of practitioners report using their own protocols with extreme variation in techniques. Although a study in 2020 aimed to standardize penile duplex Doppler ultrasound protocols, here we will give a basic and easy-to-apply stepwise technique that you can incorporate into your practice. For a man to achieve an erection, the corporal smooth muscle relaxes, allowing blood to flow into the cavernosal arteries. The increased blood flow engorges the sinusodal spaces in the corpora cavernosa and compresses the veins, preventing blood from escaping. This leads to a rigid erection. During a penile duplex Doppler ultrasound examination, we are attempting to recreate the process through the use of erectogenic agents. Therefore, it is important to ensure complete smooth muscle relaxation through appropriate dosing and redosing where needed of erectogenic agents during the examination. Before beginning the procedure, the clinician should take the patient's blood pressure. This is to ensure their blood pressure is in a safe range to proceed with the examination, as a subset of patients will require reversal of their erection with a reversal agent that may elevate blood pressure. We recommend performing a penile duplex Doppler ultrasound only in patients with a blood pressure less than 160 millimeters of mercury systolic and less than 95 millimeters mercury diastolic. If the patient requires a reversal agent, their blood pressure should be checked before administering the reversal agent and continue to be monitored during the reversal procedure, which will be discussed later in this update. The clinician may begin by using the ultrasound to take baseline measurements while the patient is still flaccid, although this is not necessary. Although there are studies presenting good predictive peak systolic values in the flaccid state, the universal consensus is in performing the penile duplex Doppler ultrasound with a drug-induced erection. The authors do not recommend performing the penile duplex Doppler ultrasound in the flaccid state. However, obtaining penile length and girth measurements in the flaccid state before beginning the examination are encouraged. Once the baseline measurements are complete and the patient is comfortable in lying supine, an intracorporal injection of a vasodilating agent is injected into either one of the corpora cavernosa of the penis to induce an erection. Vasodilating erectogenic agents such as Trimix, prostaglandin E1, or alprostadil, papaverine, and phentolamine, Bimix, papaverine and phentolamine, or Edex, prostaglandin E1, may be given. The strength and dosage of Trimix, which is the author's preferred agent, is a 30 to 1 to 10 Trimix, 30 mg per milliliter of papaverine, 1 mg per milliliter of phentolamine, and 10 mg per milliliter of prostaglandin E1 or alprostadil, given with a starting dose of 5 units or 0.05 milliliters at the initial injection. Injection should be given at either the 10 o'clock or 2 o'clock position, anywhere along the shaft of the penis. A literature review published in the Journal of Sexual Medicine found that only 50% of studies reported the use of prostaglandin E1 only for intracorporal injections, and 12% of studies did not mention which agent was used. Typically, a lower starting dose of 5 to 10 units of Trimix, 0.05 to 0.1 milliliters, is initially administered, and the patient is reassessed at close intervals and redosed as necessary. We would recommend reassessing patients every 10 minutes after injecting, or sooner if patients report achieving an erection and losing it before the physician returns to the room to examine them. After each injection, the clinician should leave the room. Ensuring that the room has the lights dimmed and/or a sound machine on can help make the patient feel more comfortable and able to achieve a more rigid erection. At present, there is no consensus about the best injectable agent or medication to use, dose, or number of injections at redosing, although there may be standardization of these variables in the future. The authors start low and go slow, injecting 5 units, 0.05 milliliters Trimix initially, and reassessing the patient every 10 minutes or sooner per patient request. At each reassessment, if the patient does not have a bedroom-quality erection or an erection sufficient for penetration, we redose and incrementally increase the next injection and reassess 10 minutes later. Our dosing schedule follows an initial dose of 5 units, 0.05 milliliters, for the first injection, 10 units, 0.1 milliliters, at second injection, 35 units, 0.35 milliliters, at third injection, and a final injection of 50 units, 0.5 milliliters, to maximize the dosing at 100 units, 1 milliliter of erectogenic agent. To get the most accurate results, the patient should achieve an erection with a rigidity of at least 8 out of 10, or an erectile hardness scale of 4 during the penile duplex Doppler ultrasound. On a 1 to 10 scale, a 10 is the best erection the patient ever had, and a 6 is just rigid enough for penetration. The scale goes down from there. The erectile hardness scale, 0 to 4, is as follows. 0, the penis does not enlarge. 1, the penis is larger but not hard. 2, the penis is hard but not enough for penetration. 3, the penis is hard enough for penetration but not completely hard. And 4, the penis is completely hard. There is not a standardized tool to assess rigidity of an erection. The erectile hardness scale is the most commonly used scale, but was only used in 14% of studies using intracorporal injections, and more than half of the studies analyzed did not mention a rigidity test. According to Nascimento et al., rigidity-based hemodynamic assessment is preferable over time-based assessment. A time-based assessment would be using a standard time interval, such as 10 to 20 minutes after injection, to measure the patient's erection regardless of their rigidity at the time. Because each patient has a different response to intracavernosal pharmacotherapy, and environmental factors can be at play, as can anxiety, there is no consensus about the dose to be administered for achieving an erection. However, ideally, the lowest dose necessary to obtain a penetration hardness erection of 8 out of 10, or erectile hardness scale 4, is preferred. If unable to achieve a penetration hardness erection, the best possible erection should be obtained, which may require redosing of intracorporal injections until the maximum of 100 units of trimix, or whichever erectogenic agent used, has been given. Once the patient has achieved a sufficient erection, or the intracorporal injections dosing has been maxed out, it is time for the examination. In patients being evaluated for Peyronie's disease, this is when measurements to assess the curvature should be taken, and the patient's degree of erectile hardness scale should be documented. For Peyronie's disease patients, measurements should include the direction of curvature, dorsal, ventral, left, right, degree of curvature, as well as uniplanar or biplanar, girth measurements, base of shaft, point of maximum curvature, and distal shaft, and distance from maximum curvature to coronal sulcus for future intralesional collagenase injection. The authors use a disposable goniometer and a flexible ruler in the office for measurements. Now you are ready for the Penile Duplex Doppler ultrasound examination. During the Penile Duplex Doppler ultrasound examination, the patient should pull the penis upwards on his abdomen on stretch. The probe should be placed in the sagittal plane and positioned at the proximal penile shaft to assess the cavernosal artery flow. You should document erectile rigidity at the time of scanning the penis, and the rigidity should be recorded separately for right and left cavernosal artery measurements. If at any time the patient loses rigidity, redosing should be performed until a maximum dose of 100 units of trimix has been given. If the patient cannot achieve an erection with the maximum dose, measurement should be taken at that time to diagnose the hemodynamics of the patient's erectile dysfunction. During examination, the peak systolic velocity and diastolic velocity and resistive indices should be measured in both the left and right cavernosal arteries. After these measurements have been taken in the transverse plane, the anatomy of the corpus cavernosum and spongiosum should be noted, and any abnormalities should be recorded. If a palpable plaque is detected, its location and any calcifications observed during the ultrasound examination should be documented. After the examination is complete, the clinician should leave the room and allow the patient to get dressed. The clinician can then re-enter the room once the patient is ready and discuss the results and/or treatment plan with the patient. It is recommended at this time to recheck the patient for a rigid erection. If the patient has an erection, the erection should be reversed before the patient leaves the office to decrease the chance of priapism. If the patient requires a reversal agent, their blood pressure should be checked before administering the reversal agent and continue to be monitored during the reversal procedure. This can be done either by taking the patient's blood pressure at certain intervals during the reversal procedure, such as every 2 to 3 minutes. The easiest way to do this would be to connect the patient to an automatic blood pressure monitor and set the interval. This is what the authors use in the office. A reversal agent such as phenylephrine can be injected intracorporally. Guidelines recommend injecting up to 0.5 milliliters, 500 micrograms of phenylephrine every 5 to 10 minutes. A maximum dose of 1,000 micrograms or 1 milliliter should be used. Patients should be warned beforehand about the adverse effects, such as severe headaches, reflexive bradycardia, and hypertension following injection. If unable to reverse the patient with a reversal agent in the office, one should be comfortable performing aspiration and irrigation in the office or sending the patient to the emergency department. It is the opinion of this author that patients should not leave the office with an erection after intracorporal injections. Interpretation of results. The classic hemodynamic parameters that are measured are peak systolic velocity and diastolic velocity and resistive index. The peak systolic velocity is the cavernosal blood velocity at the start of systole, which provides a direct assessment of the arterial supply or arterial competence, and diastolic velocity is the blood velocity at the end of diastole, immediately before systole, which evaluates the veno-occlusive mechanism. Resistive index can be calculated peak systolic velocity minus end diastolic velocity divided by peak systolic velocity, and is considered another measure of veno-occlusion. A resistive index of greater than 0.8 may be indicative of normal veno-occlusive function. Several different cutoff values have been reported in the literature, but as published by the AUA Erectile Dysfunction Guidelines, normal hemodynamics of erectile function on penile duplex Doppler ultrasound show peak systolic velocity of greater than 30 centimeters per second and an end diastolic velocity of less than 5 centimeters per second. A peak systolic velocity of less than 30 centimeters per second is evidence of arterial insufficiency, whereas an end diastolic velocity of greater than 5 centimeters per second indicates veno-occlusive dysfunction or poor venous occlusion during erection. Erectile dysfunction has been shown to be a harbinger for cardiovascular disease. Patients with very low peak systolic velocity, less than 25 centimeters per second, demonstrating arterial insufficiency, have a 3-fold higher risk of major adverse cardiac event compared to those with a peak systolic velocity greater than 35 centimeters per second. In addition, confirmatory studies based on angiography have shown that a peak systolic velocity greater than 25 centimeters per second leads to 92% accuracy in arterial integrity diagnostics. The cutoff points for peak systolic velocity are based on sensitivity and specificity. A lower cutoff would be more sensitive, but less specific. Common errors in penile duplex Doppler ultrasound. A penile duplex Doppler ultrasound is not an exact test. Many of the common errors that can occur while performing penile duplex Doppler ultrasound have been mentioned here, but there are several things you can do to optimize the accuracy of your study. One of the most common problems is that the patient is in an artificial environment. Clinicians should make the environment as comfortable as possible to allow the patient to achieve their best bedroom quality erection, or the most rigid erection possible. The patient may already have stress or anxiety about the results of the examination or the process itself, not to mention his own erectile difficulties. Furthermore, the doctor's office is not the normal setting for a man to obtain an erection. As a result, this stress causes a release of adrenaline, a potent vasoconstrictor, which is known to negatively affect erectile function. In fact, the most common cause of a falsely abnormal examination is due to inadequate smooth muscle relaxation from either low arousal level or high levels of adrenaline. As a result, the literature has demonstrated that up to 50% of corporal veno-occlusive dysfunction cases can have a false diagnosis. Adrenaline promotes smooth muscle contraction, limiting cavernosal artery relaxation and maintaining the cavernosal smooth muscle in a hypertonic state that prevents the veno-occlusive mechanism from occurring, which is paramount to achieving an erection. Therefore, doing everything to optimize the environment for the study is imperative. Another common mistake is not injecting enough of the intracorporeal agent to maximize the erection. If you do not maximize the dosing until a patient has achieved a sufficiently hard erection, then stress or adrenaline can overcome the medication, leading to false results or a delayed erection after the penile duplex Doppler ultrasound has been performed. Without an adequate erection, a patient can be falsely diagnosed with veno-occlusive dysfunction. It has been shown that if patients with a diagnosis of veno-occlusive dysfunction on the first test, repeat testing or confirmatory testing with dynamic infusion cavernosometry demonstrates that only 43% of the patients were actually confirmed to have the diagnosis. Suboptimal intracorporeal injections dosing or neglecting to redose patients correctly until the maximum dose of intracorporeal injections agent has been given or a sufficient erection achieved will give false results that do not accurately represent the patient's erectile hemodynamics. Again, this stresses the importance of dosing the patients correctly and increasing the dose until adequate erectile hardness has been achieved, or you have maximized at 100 units, 1 milliliter of erectogenic medication. Waiting too long in between injections or to re-examine the patient may lead to false results. Performing penile duplex Doppler ultrasound should be done in a fashion that allows set intervals between intracorporeal injections to reassess the patient's erectile hardness and redose as needed. Oftentimes, clinicians may schedule penile duplex Doppler ultrasound in between regular patient visits, which may lead to delays in performing the study or evaluating the patient if regular patient visits run overtime. In addition, if a patient does not have a penetration hardness erection, it will be challenging to correctly measure the true degree of curvature in Peyronie's disease. Suboptimal erections during curvature assessment with penile duplex Doppler ultrasound will underestimate the true degree of curvature and may miss identification of biplanar curvatures, hourglass deformities, tapering, or indentations that can be important for surgical planning. If the clinician does not take the time to re-examine the patient for persistence of or attainment of an erection after completion of the penile duplex Doppler ultrasound, a priapism can be missed. After the examination, when the patient has had time to redress, they often are able to relax and their adrenaline levels decrease, promoting smooth muscle relaxation, which is necessary for formation of a rigid erection to occur. If the clinician does not allow sufficient time between the examination and re-evaluating the patient in the office, this can be missed, and the patient can be falsely diagnosed with veno-occlusive dysfunction or arterial insufficiency. Further, a missed priapism is a medico-legal matter and can lead to permanent erectile dysfunction. All persistent erections in the office should be reversed before the patient leaves the office. The blood pressure must be monitored before injecting the intracorporeal injections, but also before reversing the erection if necessary. It is also important to remember the technical considerations discussed earlier in this update to get the best and most accurate results. The clinician should know how to properly read and interpret the ultrasound results, hold the probe correctly, and properly save the results. This will reduce errors. Many training courses for learning how to perform penile duplex Doppler ultrasound are available through local ultrasound company reps, and the AUA or Sexual Medicine Society of North America conferences and workshops. Conclusion: Penile duplex Doppler ultrasound is a low-risk, cost-effective method to evaluate patients with sexual dysfunctions, including erectile dysfunction and Peyronie's disease. Despite this technology being used for decades, there is no standardization of how to use this technology to produce the best results. However, it is an easy-to-learn procedure that should be considered in men presenting with sexual dysfunctions as another diagnostic and often therapeutic tool. Did you know? Penile duplex Doppler ultrasound is a cost-effective, accessible technology that can be easily used in the office to help diagnose sexual dysfunction, such as erectile dysfunction, Peyronie's disease, penile fractures, and more. Penile duplex Doppler ultrasound is best performed using a machine capable of color Doppler waveform analysis and a high-frequency 10 to 15 MHz probe, intracorporeal injections to induce a rigid erection, and a readily available reversal agent such as phenylephrine. A peak systolic velocity of less than 30 centimeters per second is evidence of arterial insufficiency, whereas an end diastolic velocity of greater than 5 centimeters per second indicates veno-occlusive dysfunction, or poor venous occlusion during erection resulting from defective corporal smooth muscle. Having an inviting and relaxing environment for penile duplex Doppler ultrasound is important to best assess a patient's erectile function and obtain accurate results. The authors thank Matt Ziegelman, MD, for his help with figures in this lesson.
If you've enjoyed this episode, would like to hear more episodes like this one, or are interested in the AUA Update Series, please visit the AUA University at auanet.org/university for more information or to purchase your subscription today.